Well, hello everybody. Today we're going to start talking about skin integrity and wound healing. This is from your chapter 29 in your Craven book. What does the skin do? Essentially, skin provides protection. On the outside of our skin, we have sebum that is acidic in nature and decreases the growth of any microorganisms on your skin. It also helps protect us from the sun rays. We have melanin in our skin, so that helps protect us. It provides thermoregulation. We can lose a lot of warmth and heat through our skin. So this is why with young babies, we provide hats for them when they're newborns. As adults age, we lose that protection, and so we may wear more sweaters and jackets. We also lose a lot of fluid out from our skin as well, so we need to bear that in mind. Sensation, we have a lot of nerves in our skin, so it helps us feel. And metabolism, from UV rays, skin synthesizes vitamin D, aiding in the proper absorption of phosphorus and calcium, thus bone restoration and maintenance. So we need to make sure that we get adequate amounts of sunlight every day. And also, skin helps us communicate. We're able to do the facial expressions, the color of our skin, the bronze look can be seemingly more attractive, so our body appearance in general. So how do wounds occur? Wounds occur because of exposure to extreme temperature. pH can be altered related to different disease processes such as renal, hepatic, or endocrine, just to name a few. Wounds can occur through exposure through caustic chemicals, excessive pressure, moisture, friction, trauma, and radiation. And we're going to talk about some of these today. As we age, there's certain changes that occur. I think this picture is a great diagram just to show how as we age, what happens to our skin. It becomes a little bit thinner. It loses its elastic fibers. We have less active sweat and sebaceous glands, so it tends to dry a little bit more. We have collagen changes as well and reduced circulation. So this means that our healing is not going to happen as quickly if it becomes damaged. Nails become thicker, thus more brittle. Hair will lose its pigment and thin. We develop benign skin growths or age or liver spots. And that happens largely because of our exposure to sunlight. So what affects our skin? Circulation, nutrition, many things affect our skin. And I love these pictures. It's a classic example of being exposed to different elements. Circulation, say cardiac disease or hypercholesterolemia, it can impair the circulation. Nutrition, if you have a well-balanced diet, rich in vitamin A, B6, vitamin C, niacin, copper, zinc, your skin will be a little bit more healthier. Conditions of the skin, such as breaks in the skin, improper skin care, if you're incontinent or sweat a lot, all these factor into your skin and their condition. So good hygiene. Dermatitis and increased thickening of scarring affects the integumentary function. So allergies, antibiotics, and immunosuppressive therapy increases risk for candida infections. And different diseases such as inflammatory bowel and peripheral vascular disease do affect our skin overall because it's taking nutrients out of the body. Trauma, either accidental or surgical. Excessive exposure, so the good old sun. Also tanning beds, we must not eliminate those. Seniors also have the increased risk of burns and decrease in dermal and subdermal layers, so the decreased fatty stores. So they're increased risk of having skin damage or skin problems because they do not have that fatty layer. Mechanical forces, we'll touch on that in following slides and go through each one of them specifically. The first one is friction. This is an example of some friction tears. It's basically where you have the skin that rubs against a firm surface You can be wrinkled bedding during turning or handling, poor lubrication of skin, and it increases the possibility or the risk for ulcers. Then you have shear, and this is where you have two layers that move on each other. Say when you bring the patient up or up in bed, or the patient is sliding down in bed. It's where the skin remains immobile while repositioning in the opposite direction. So we need to be very careful when handling our elderly patients that need to be moved in bed or as they slide down in the hospital beds. Then many of you, I'm sure, have heard about the pressure ulcers. It's where a localized area of tissue becomes necrotic or is destroyed. The cells die, they decompose, and an ulcer forms. It's often over a bony prominence. And if non-viable tissue remains in place, staging is not possible. So the only way we're truly going to know what stage of pressure ulcer that patient has is if we debride that wound. So we need to open it up, especially if it's, more particularly if it's spongy. If you notice, it's a very soft, spongy feel. Thorough identification and assessment is important, but overall, prevention is key, and we'll talk a little bit more about that in a minute. Those increased patients that are at risk are those patients that are hospitalized or bedridden, wheelchair bound, or have certain apparatus such as your nasal cannula, or maybe use specific walking devices, but they're not using them properly. So we need to be aware of that, or shoes that can even be too small on them. There's a variety of factors that increase their risk. Other factors are excessive moisture, obviously your friction and shear injury, impaired nutritional status, changes in the sensory and perceptual ability and levels of consciousness. And it's important for us to do thorough Braden skin assessments on our patients. We have the Braden skin assessment both in your book, and you also have it in your clinical paperwork. Take the opportunity to have a look at that, and if you have any questions, please ask in class. Diabetic neuropathy or paralysis also puts your patient at increased risk. And also there's other factors that affect wound healing. It could be age, obesity, smoking, medications, stress, and also nutritional intake. This diagram here shows a progression of a decubitus ulcer. In the first picture on the top left, you have stage 1, which is persistent red, blue, or purple tones. And as you can see, there's no open sore or open skin area at this point. Now, that does not necessarily mean that there isn't anything under the surface. Okay. Stage 2 is your partial thickness skin loss. It's where it presents as an abrasion or a blister. Now, this is what I mean. It doesn't always mean it's not under the surface, because you can still have a skin layer on your stage 2, but you'll feel more spongy in nature underneath, and it'll bounce back. And it's a distinct difference in the normal tone of the tissue. Stage 3 is where you have full thickness skin loss, and this is in your bottom left-hand corner there. It's with damage or necrosis of the subcutaneous tissue, and it persists in a deep crater. You'll have it get deepening. And remember, the only way we can stage these is if we actually have it open. Stage 4 is where you have the full thickness skin loss with extensive destruction, necrosis, or damage to the muscle, bone, or other structures. So it's a very deep wound, and this is on the far right corner, bottom. Here are some other examples. So your key assessment is going to be staging. We want to look at that. We want to be able to debride it away so we can get the full concept of what stage this ulcer is. We want to look and see if there's any wound drainage, and if there is, what is the color, the amount, the consistency, and the odor. Does it have a smell to it? Is it yellow in nature? Is it thick? Is it draining clear liquid? So is it serous, serous sanguinous, serosanguinous, purulent? Know your terminology. Get those down. We do have a handout that should be on Canvas for you guys. It lists some of this information for you. You want to look for signs and symptoms of infection, and you want to look at the condition of the surrounding skin. And overall, you do want to do a measurement to ensure that when you have a clear understanding of the size of that wound and you do some wound care on it, that you watch the progression of that wound. Prevention is less costly than treatment, so what do we need to do? We need to do a lot of patient teaching, a lot of staff teaching. We need to teach our patients about good hygiene, protection from the sun, turn and repositioning of the patients. How frequently should it be done? Generally, it's every 2 hours. So follow with your policy and procedure with your facility and make sure that you turn our patients. Support surfaces for pressure management. So provide pillows, boots, sheepskin. You've got mattress overlays. You've got air mattresses. We have a lot of different resources out there that we need to make sure that we utilize them. Make sure those mattress overlays are 4 inches in depth. 1 inch is not going to cut it. That's not going to provide a lot of support for your patient. If they are a larger patient, provide them with a oscillating air mattress or a bariatric bed. Special care on those bony prominences. Provide corrective positioning using pillows and other equipment that is on offer to you at your facility. If your facility does not have it, make sure that you be advocates for your patient and order those supplies to make your patients more comfortable. As an RN, you will be an advocate more than you really acknowledge in the beginning. They look to you as their resource, their savior, their support, the person that's going to be able to speak for them. So utilize your skills of good communication and negotiation to be able to get those resources in for your patients. Infection control. Our patients are extremely compromised. Any of your breaks in the skin and mucous membranes, invasive devices such as IVs, stasis of blood fluids. When they're immobile, they're higher risk for developing DVTs. Stress and hyperglycemia can increase the risk for poor nutrition to the skin or breakdown. Immune system dysfunction, again, increases the risk for infection. Coexisting medical conditions such as diabetes, obesity, cancer, anxiety, alcoholism, all of these affect their body's ability to heal and to maintain good skin integrity. Different medications and drug therapy also puts them at additional risk. And don't forget that we have a very broad border here in the U.S. We border on to other countries. We also have people that are traveling a lot. That also puts people at risk. So if they've come into your facility with skin infection or in a respiratory infection, anything, make sure that you question your patient and get an idea on where they've been traveling to, what they've possibly been exposed to, or maybe they've got family members that have traveled and brought something back. Your patients also have urinary retention and bacterial growth that increases their risk for infection. Stress and hyperglycemia decreases the ability of wounds to heal. Increased sugar just loves to breed bacteria, so bear that in mind. So not only your skin, but just generalized infections. Pressure ulcers can go septic very quickly, and amputations necessary to provide wound closure and sustain life will need to be implemented. So we need to make sure that we follow up on our patients and give good education on prevention as well as improving the healing of that wound. Remember that if your patient does go septic, that can lead to death very quickly, especially with coexisting comorbidities. So infections as a cause of death in older adults are exceeded only by cancer and myocardial infarction, so it's very high on the list. Our nursing interventions, our responsibility is to provide analgesics, rest, sleep, cloth to the head, warm blankets, tepid baths, IV medications in severe cases, ambulation and positioning, respiratory interventions, fever management. We're going to discuss many of these in future lectures in more detail, but I want you to consider the increased risk to your patient with comorbidities. And remember that a slight increase in a fever or in a temperature could be more compromising for your patients that have severe comorbidities. And elderly patients are more susceptible and more sensitive to heat and cold. And remember, there are other things that can cause an injury or a sore on a patient. Nurses wearing rings, that's why we want to minimize your wedding rings or your jewelry, anything that can injure your patients. Tape being removed from patients' wounds or IV sites, wrinkles in the bed sheets. Maybe it might be something inadvertently dropped in the bed. Maybe it's keys, maybe you've dropped a cap to a needle or a pill cup. Even a patient's skin, maybe a fold in their skin, that can increase your patient's risk for developing a bed sore. So there's lots of things we need to be observant of. Start thinking about your patients that you're going to come across in the nursing home setting and how you can prevent or minimize their risks. Look at their skin, observe it, look at every portion of their bodies, especially their bony prominences. Prevention is key. Please feel free to bring your questions to class and we can discuss them as a group.